As an interventional cardiologist, many people would assume that my primary modality management, I'll start again.
Yep.
It's continuous, right?
Yes,
yeah, okay, sorry, okay. As an interventional cardiologist, many would think that my primary treatment modality for the management of patients with angina would be PCI or stents. And the reality is I think as physicians, as clinicians, we have to be a little bit more thoughtful than that and really ask our patients what they hope to gain, what their limitations are, but be thorough and assiduous about how we do that. For example, there's pretty good data out there that suggests that many physicians don't really characterize their patients' symptoms very well. Data published out of the Mid-America Heart Institute suggests that many patients, for instance, might report significant anginal symptoms and limitations if you were giving them a validated angina assessment instrument like the Seattle Angina Questionnaire. But yet their physicians don't actually figure out that they're actually having these symptoms. And perhaps that's because in the current environment with EHRs and shortened visit times, it's really challenging to take a good history. But it's also because sometimes physicians, and we see this with our fellows and residents all the time, will ask a patient, so are you having any chest discomfort? The patient says no, and then they move on. And oftentimes for someone like myself who sees tertiary patients or second opinions or turn downs from other physicians, what will happen is you talk to the patient and they may not be having chest discomfort, but then when you ask them what they actually can do, in other words, are they able to walk to the end of their driveway, or what would they like to do? They say, I really don't think I can do those things anymore, or I can't do them anymore because I'm limited. Then the story starts to tell itself. So I think the first piece of this is really trying to get a good sense of what your patient's symptoms are and how limited they are in terms of their symptoms. I think the second part of anginal management then comes with what the patient preference is in terms of how to manage it. Many patients are very afraid that they're going to drop dead or have a heart attack, and for many patients, especially if you've defined their coronary anatomy and shown that they don't have prognostically important disease, left main, multivessel, proximal LED type of disease, those patients could be managed medically if that's what they wanted to do. But that's the biggest challenge that I see in current medicine, in the sense that we as physicians often decide for the patients and say, well, I believe you ought to have this, rather than asking the patient, do you want to take medicines instead? How important is it for you to not be on medications or to sort of reduce the number of medications you're on? Because I think for many patients, they may be afraid to tell their physicians, look, I really don't want to start that medicine that has side effects associated with it, or that other one that may have a really high copay associated with it, and they'll just listen to their physicians for advice. So I would say we ought to turn it around 180 degrees and listen to our patients and ask them what they want to do and how they feel about it. Because sometimes for symptom relief alone, if we're escalating medicines, that really commits those patients to medicines for life, and many patients would opt rather to go for a quicker fix, if you will, and a fix that potentially could limit the amount of medications they're on and also increase their capacity to be vital and exercise and the like. That's not to say you can't do it with medicines, but some patients we don't even really give that chance and ask them. Obviously this is a patient population that I see predominantly, as mentioned before. It's a referral population and people with second opinions, but it's still important for all physicians to kind of take that into account. And then finally, I think it's also important to be really firm in our belief and understanding of what the data is for various therapies we have out there. There's some therapies that physicians will tell their patients, I've put a stent in, I've saved your life. That may be true in some cases, it may not be true in other cases. It's very important to really be dispassionate about how we present the data, because ultimately we're a patient advocate first, and that's how we're trying to take care of patients in real life.